Welcome to the PODdoctors. I am Dr. Damien Dauphinee, and I'm here with my partner, Dr. Raafae Hussain. My specialty, podiatric surgery, and Dr. Hussain's specialty, podiatric surgery, is a medical specialty and is becoming a very integral part of treating a number of major medical problems in the United States these days, particularly diabetic problems. Patients with diabetes have all kinds of foot-related issues, and so over the course of the next several weeks, we'll talk about some of the things that we see on a daily basis, that we treat both surgically and non-surgically, and you'll get to know both of us, kind of what we're all about. But we hope that this is educational. We want this to be more of a conversation and not really a lecture. We do have, hopefully, some PowerPoint templates that people can refer back to. This will be available on YouTube. It'll be available on Spotify, Apple, any place where you get your podcasts. And we would love for you to give us feedback. Tell us what you want to hear about, what you're interested in, what you don't understand about maybe a foot problem that you're having. We're not going to diagnose things on this particular podcast, but we will hopefully be able to provide some insight and maybe some direction as to what you might be dealing with and how you might be able to address it. So, Dr. Hussain, what is a podiatric surgeon?
Podiatric surgeon. So when I told some family and friends that I was going to go study podiatry, they were like, "Oh, kids, wonderful," right? and I had to explain to them that podiatry is actually foot and ankle, a specialty that, just like any other part of the body, we're here to take care of. So what is a podiatric surgeon? We go through podiatry school. It's a specialty school that specifies in lower extremity problems, but as far as training, teaching, classes go, we're doing the same classes as all med schools. I want to say all but one podiatry school is affiliated with a medical school. Typically, they'll share classes. Same professors, same doctors.
So I think there are 10 podiatric medical schools in the United States right now. People might be surprised to hear that's the number.
And there's a new one coming out in Texas.
An 11th that is being started down in the Rio Grande Valley with Dr. Larry Harkless, who was actually the podiatric surgeon and podiatric physician who started the program out at Western Medical School, the osteopathic school in Pomona, California. Yeah. And he's also been integral in residency training here in Texas for, I think, almost 4 decades. He's been doing this for a very long time and has been in education for a very long time. So he's the perfect person to be helping them with a podiatric medical school that'll be kind of bolted onto the medical program down at the new medical school and medical campus down in the Rio Grande Valley here in Texas. Certainly where they have tremendous need for what we do.
Yeah.
I think it's important to maybe delve into what our training's all about. We both graduated with undergraduate degrees in the sciences. I went to the University of Notre Dame and got a bachelor's degree in pre-professional studies, which is essentially Notre Dame's version of a pre-med program. Go Irish! We just beat Clemson this past weekend, which was awesome. So I'm going to put a little plug in for my Irish. And then, Raafae, you graduated undergrad. Where'd you go to school?
University of Hartford. I was part of the 3+4 pre-med program, and when I was finishing my 3rd year, I had the choice of going to like osteopathic schools, MD schools, or a podiatry school. So I kind of
looked at them all.
I kind of fell into podiatry. I got the push from my family, and I had this one doctor, family doctor, longtime friend. My mom worked with him. Very well known, and he teaches at Columbia and all that stuff. And I was like, "Hey, Dr. Wartzberger, what do you think about podiatry?" And he's very, very Brooklyn accent, has a beard and Hasidic curls and stuff. He's like, "Raafae, let me tell you, podiatry is going to be one of those fields that's going to be here now, and it's going to be here forever. You have only but growth in your future." And I was like, this guy knows what he's doing. He's been in practice for 20, 30 years. let me look into this a little bit more, and I kind of just fell into it. It has a little bit of biomechanics, it has a little bit of surgery, it has a little bit of clinic.
Very procedurally oriented. You know, I mean, I think that's one of the coolest things about our days in the clinic. I mean, I'll see 30 patients in a day, and it is going to be such a wide variety of things that we treat.
Yeah.
And that's, I think, one of the coolest things about our specialty is we're not doing the same thing every day at all. And a lot of them are vital to patients' survival of limbs, which I think is extraordinarily important, obviously. But also just treating chronic pain, trying to treat injuries and dermatologic conditions and things that are causing chronic pain for patients and having an effective answer for them, I think is really one of the greatest things that we get to do every day.
Yeah, and that's why we need a broad background. All our training has to have, it has to be just from like derm to infectious disease.
It's got to be based in the sciences. It's got to be based in the basic sciences, and I think that's what you're showing here with this slide here. Year 1 and year 2 in podiatric medical school, and it would run right alongside year 1 and year 2 of any allopathic medical school.
Yeah, so we're doing from everything from like biochem to bacteriology to derm to neurology, anesthesiology, medical ethics. I mean, everything in between. Our 3rd and 4th year, where we kind of jump in a little bit more specific to podiatry, we'll be doing podiatrics, that's our children, our peds, geriatrics. We'll do medical imaging, which will focus more on podiatry pathologies, but I would learn how to read a chest X-ray, or learn how to read, everything in between.
Sure. So we're spending a significant amount of time in internal medicine, medical imaging, like you said, the functional orthopedics, physical medicine and rehab, and then in that 6th semester, delving a little bit into emergency medicine, more internal medicine, advanced imaging, and then you're getting some of the specialization, the podiatric surgery, foot and ankle, 3, clerkships, traumatology. What was Capstone Clinical?
So Capstone is something probably that came out a little bit after you went to school. So that's like a physical assessment exam type of class where, aside from books and lectures that you're learning, this was
so we're doing physical diagnosis.
We're doing exactly.
Yeah. Okay. We had that too. Yeah. We actually.
But this was an exam that actually had to take.
We did too. This was real patients exam. So yeah, we did that with Loyola Medical School, Rush Medical School, and Northwestern. All went through Rush, the Rush program in Chicago, where you had to do the live patient diagnosis, physical diagnosis classes, and you had to be able to examine the patient from head to toe.
Yeah.
And they're gonna show up with different maladies, and you're gonna have to diagnose that.
Yeah.
And order the appropriate studies, and that was the only way you could pass that part of the course.
Because multiple choice exams are kind of easy.
It is what it is. But you got a real patient in front of you, and you've got to determine if they're having a heart attack or a stroke, or they've got obstructed bowel or whatever it might be. So I think we clearly had to do the same thing, and that's why I've been doing my own pre-surgical history and physicals for 21 years, and why we have that privilege. So.
Yeah.
And then when you get into year 4, this is really where you're doing externship programs. So you're going out to other residency programs, spending a month here, a month there, where you think you want to do your residency.
Yeah. We
had that same thing, and then spending more time in the OR, more time learning surgical techniques, and it looks like senior orthopedics and podiatrics. We had a similar last semester there. Before you start residency, so all that is in preparation for then going through the match, just like any other medical student, and then getting hopefully matched with your favorite be-all end-all surgical residency training program.
Do you remember that stress waiting for?
It was brutal. I was fortunate. Back in that period of time, you could actually be approached by a residency program, and they could say, "Hey, look, we really like you. We're gonna match you as one of our top 2."
Yeah.
And then you can drop out of the match. And I was fortunate; I got my second choice, and dropped out of the match. So I got the second best program that I thought was going to be the be all end all.
Wow.
Having said that, the first year was great, but then the program was having problems, and I left that program. They were having some issues with the leadership, and the hospital was being purchased at the same time. So we were all worried about whether the program was going to continue, and I was like, okay, I'm out of here. So I jumped and went to a new program in St. Louis, and so I did 3 years of surgery with 40 or 50 different attendings. Everything from, spending a tremendous amount of time with our general and plastics guys, our vascular surgeons, orthopedic, and then podiatric surgeons. So I was fortunate. I literally worked with at least 45 different surgeons on a regular basis in 3 years, and did a ton of cases, to the extent that I didn't feel the need to do a fellowship after that, even though a few of them were available back then. But you actually completed your residency, and then you did a fellowship.
Yeah, so after residency, I had the opportunity of working with Dr. Malay. He's the fellowship director at UPenn, the head editor of JFast. So our fellowship was actually more based on research and methodology. It was all, foot and ankle surgery, advanced foot and ankle surgery related. But, we'd be working on the literature behind it. So we'd have an interesting case or an interesting couple of cases, and we're like, look, why don't we try to get this published? Let's get the know-how out on this. Let's see, like one of our studies, and still ongoing, is ultrasound guided plantar fascia injections more appropriate than just anatomical guided plantar fascia injections? I mean, simple things that we're doing, day to day in clinic, but see if there's just a little bit of an extra benefit of one way or another.
Sure.
It
was
was
adding to the medical knowledge out there, which is terrific.
Yeah.
And he puts out a great product. The Journal of Foot and Ankle Surgery is a tremendous peer-reviewed journal that, he's a stickler. Yeah. And we've tried to get things published in that journal before, and Scott is a tremendous statistician and delves deeply into the numbers, and he will rake you over the coals before he publishes your paper, which is great because he puts out a tremendous product.
Yeah, he's by far one of the smartest people I've ever met. I mean, this is a...
Maybe we can get JFast to sponsor the podcast. Now that we're just blowing smoke up his skirt. But no, Scott really is a good dude and a tremendous asset to podiatric medicine and surgery here in the United States for sure.
Yeah. So, I mean, let's talk about things that we typically see in clinic. It ranges. It goes from nail pathologies, nail funguses. There was an interesting paper in JFast that was talking about how when we see these nail funguses that we see clinically, when we take the cultures and send them off, like you typically do, that only 50% of them were coming back positive for fungus. So, I mean, I know a lot of patients will be like, look, I think I got nail fungus. What do you want me to treat it with? Well, I kind of do like the back step. Like, let's see if it's nail fungus before we do anything.
Because you can't really eyeball it and know for sure. Yeah. I mean, I'm probably maybe 70% correct, but, it'll come back lichen planus, psoriasis, a number of other dermatologic conditions which can mimic some of those changes that patients are worried about, both from a cosmetic standpoint and also sometimes from a pain standpoint.
Yeah, I mean, in conjunction to that, same thing with skin pathologies. Patients will come in and be like, look, I think I got a wart, and ends up being a corn, ends up being...
Or porokeratosis. Yeah, we see those all the time, and there's a completely different protocol for treating those. Yeah. Even something as simple as just scaly dry skin that they think is just dry skin, and it's really tinea, so it's really a fungal infection. Yeah. And skin scraping. Yeah, skin scraping can tell you a lot about that. So I think we're biopsying things a lot more now. Yeah. We're a little more aggressive with that because have you seen the poster we have up in the office showing all of the lesions that you think are just benign lesions, and every one of them is malignant melanoma?
Yeah, I had a patient last week. Last week I took a punch biopsy, and I'm almost certain that it's going to come back as something serious. Something squamous cell.
So I think all of these dermatologic conditions that we see, almost every day, they have to be worked up in a specific way. Otherwise, you're just going to be spinning your wheels treating something that that either needs a completely different approach or is untreatable.
Yeah, a lot of patients will be like, "Hey, can I get a steroid cream?" And I'll be like, let's see what it really is.
Let's find out a good diagnosis, hang our hat on that diagnosis, and then if it needs a steroid cream, we can go that route.
Yeah. Next thing, very common, plantar fasciitis, the dreaded heel pain.
Oh yeah. This is the most common thing we see in the office on a daily basis. It does not discriminate. It affects old, young. Doesn't matter who you are. If you're active or you're trying to become more active, you may end up with some plantar fasciitis, and me included. I've had it before.
Yeah, me too.
Yeah, it's no fun.
Yeah. So I mean,
we're going to spend an entire episode on this, so we're just going to touch on it today.
Yeah. And not all heel pain is plantar fasciitis.
Correct.
I mean, it could be a stress fracture. It could be Baxter's nerve entrapment. It could be a Hagelin's deformity. It could be Sever's disease.
It could be tarsal tunnel syndrome.
I mean, It could be a whole variety of things. So not all heel pain is the same, and we'll go through the lecture on this.
Mm-hmm. It's worth it. It's worth to spend the time to kind of get a little deeper into plantar fasciitis and heel pain and what it involves, because I think there are so many different etiologies.
Yeah. Sprains versus strains. I mean,
that's another one we need to spend all day on. And that video you picked out is just wicked, brutal. Yeah. Watching that poor woman go down, that's just, that's awful. I'm surprised if she didn't end up tearing a knee ligament. But anyway, go ahead.
So strains versus sprains. There's over 100 plus ligaments and tendons that come down to the foot and ankle that pretty much support our foot structure. And we'll go through these individually, one by one, talking about the common symptoms, the common etiologies, and treatment options. And there's a lot of things. Ankle sprains are probably the most highest of all injuries in athletes, if I remember correctly.
Yeah, I think you had a stat on that where it's one of the most common injuries in the human body, period.
Yeah, I want to say it was like 15% was ankles, and then the next count was like 5% was like ACLs or something like that.
Right. They pale in comparison. So I think it's certainly, that was what got me into podiatric medicine and surgery, was sports injuries. I originally thought I wanted to do podiatric sports medicine, and found along the way that dealing with athletes was, let's just say, less than appealing after a while, mostly because they don't listen to you. And I still deal a lot with athletes and amateur athletes and their parents sometimes. And sometimes their parents are equally difficult to deal with, because I think the expectations for some of these kids are very high, and they want them to be college athletes, and they want to get them back to their sport as quickly as possible. But sometimes, time is the enemy for some of those things, but is required for these things to get better. And that disconnect is sometimes very difficult. So I kind of gravitated away from that to adult reconstruction and peripheral nerve, where I think patients have a little bit more of a realistic expectation of how long things are going to heal. So, but just me personally, that was kind of where I gravitated. But I remember, looking at podiatric medicine, thinking, "Oh, this is a pretty cool specialty. I can have like a regular life. I don't have to be on call 24/7.
Yeah, I
can treat athletes if I want. I can do wound care. I can do all these different things." Not to get off on a complete tangent, but that was kind of where what brought me into this specialty.
No, it's true. I think we can say confidently that if you want to be a non-surgical specialist in podiatry, you could. You can do all clinical stuff.
Biomechanics.
If you want to do,
and we have those here in Texas, sure.
Yeah, and if you want to do 90% surgery, you can do that too. It's just how you want to build your practice. If you want to do sports medicine, if you want to do pediatrics, if you want to do geriatrics, it's per person what you make of it. And that will be the subspecialty of podiatry. And
we have a lot of women that get into this specialty because of the ability to have kind of a regular life and not necessarily be on call all the time. Be able to work 9 to 5 and be able to go home and spend time with your kids and your family. So I think it's appealed to a lot of women out there. I think the numbers of women entering podiatric medicine and surgery over the last 20 years have gone up significantly.
Yeah.
For that reason, I think.
So bunions and hammer toes, very, very common thing. It's kind of our bread and butter as far as what people think that we do.
It's the foot deformity with the funny name.
Yeah. And most of this, we can slowly prevent from happening with, orthotics and similar things. But once it gets to it, it's usually finally a surgical decision. And we'll go through the multiple options as far as surgery. I want to say there was like 180 plus ways to fix a bunion.
A ton.
Yeah.
I think you pick. It is one of those problems that if you choose the right version of surgery for that particular deformity, you can have excellent results and very very repeatable and standard results. And I think people kind of have a strange misconception about the amount of post-op pain involved. But we use multimodal pain relief. We use a combination of non-steroidal anti-inflammatories, narcotics, and even things like gabapentin sometimes. And I think our patients are taking pain medication for 2 to 3 days after surgery and doing quite well. So, it's certainly not something that patients should avoid if it's starting to affect their other digits. And you can see in the picture on the left there where the great toe is underlapping the second toe and it's creating that hammer toe. If they're either having pain in the joint itself or having the great toe start to deform the other toes, that's really when something should be done. Otherwise, you're going to end up seeing the great toe destroy all the toes and throw them all out of alignment. So, that's really my protocol. I don't know about you when you recommend surgery.
Yeah, it's a progressive problem. I say if you're very against surgery, by all means, we can figure out other ways of trying to reduce the pain. But if you're kind of on the fence or doing your research on surgery, I say get it done because it's a progressive problem. It's only going to get worse. And
you don't want to have to fix all 5 toes if you don't have to. And sometimes just fixing the great toe and the second toe and that's going to be sufficient.
Yeah. Flat feet. That's kind of my favorite topic right there. So
this is a very complex, multifaceted problem that I don't know that it gets enough respect because you think, the patient just has flat feet. Maybe back in the day that used to get you out of the military service, but I mean it's a very common problem. It's a progressive problem again, and there are many adults that had very flat feet as kids, and now they're dealing with osteoarthritic changes in the midfoot.
Yeah.
So it is something that should be addressed on multiple levels, both with bracing and orthotics, and at some point, in many cases, surgery. So I think we're both identifying patients who are struggling with this as adults who maybe could have had something done sooner in life and been able to avoid some of that.
Yeah, I 100% agree. I mean, as it comes to flat foot, I mean, it's a very debilitating problem when it gets bad. And when we can correct it while they're young and happy, young and healthy, it's far simpler because we're going in, we're realigning joints, we're not fusing joints, we're not doing anything too aggressive. We're realigning the foot to be more biomechanically sound. But as you get older, the joints become more stiff, more arthritic, the tendons are far more injured, and we're doing more aggressive things to fix the foot.
Yeah, that's where you've got to stabilize the rear foot by fusing rear foot joints, and there's not a whole lot you can do to get around that. And then there's always bracing. I mean, ankle foot orthoses or AFO braces can be helpful, and we'll talk a little bit about that because I think we have a whole episode dedicated to this where we can get a little more in detail on that.
Fractures. So,
these are fun.
So we see from everything from toe, metatarsal, midfoot to ankle fractures, and they all have their fun little quirks to them. But I mean, by far the most common are probably stress fractures. Your common marchers fractures, runners fractures.
Neck of the metatarsal. Yeah, just like that lower left picture, you can see the neck of the third metatarsal where you've got that thickened area and it looks more white than the rest of the bone. That's a classic stress fracture where you don't see a through and through fracture, but the bone's clearly been disrupted, and now you're seeing the healing cascade with the healing callus around the fracture site that occurs 3, 4, 5 weeks down the line. Now that calcaneal fracture you have in the upper left, those are sometimes extremely challenging because the Achilles tendon is literally pulling that piece of bone away from your fracture line.
It's like a rubber band.
Yeah, and I've seen those treated conservatively with casting, and that is a miserable failure.
Yeah.
I've unfortunately had a colleague of mine here in town who tried to do that with a patient just a couple years ago, and he was diabetic and he was a complex patient. But he was certainly a surgical candidate, but they chose not to, quote unquote, because of his diabetes, which I think it's probably a mistake because this patient ended up having all kinds of problems to the extent that the fracture pattern got so bad, it got so widened that he eventually broke his ankle.
Oh, wow.
His heel was so out of position, he eventually broke his ankle brushing his teeth. So he just turned funny, rolled on the heel, and then snapped his fibula and his medial malleolus. So, clearly there's a point at which, even in patients who have diabetes or other medical problems, that surgery is still probably in their best interest because of the alternative. So if somebody has reasonable blood flow to the limb, they have controlled diabetes, reasonably controlled diabetes, they're still potentially a candidate for an open reduction internal fixation, which is what we have here with the screws and the washers, fixating that fracture perfectly. So, yeah, we are seeing these patients. They walk in, we see them in the ER. We'll see them, at the hospital from time to time. And if these problems aren't corrected extremely well on the front end, they can lead to post-traumatic arthritis on the back end. And even when you treat them effectively on the front end, people can still end up with post-traumatic arthritis.
Hopefully to a lesser degree.
But that's one thing you have to understand is, man, once you've had an ankle fracture like this dude down here on the far right, that's a fracture dislocation. That joint's never going to be the same. And you can fixate it, and this looks like it was fixated extremely well.
Yeah.
They addressed the syndesmotic injury, they addressed the fibular injury, and they got the talus back into the mortise, and that's about as good as you can hope. But even with that, you can still end up with problems down the line. So we see folks sometimes who've had ORAF, open reduction internal fixation 20 years ago, and now they're starting to have some early arthritis.
Yeah, it catches up with them.
Yep, and so that's certainly something we have options for. We have bracing for that. We can also talk to them about ankle replacement, or ankle fusion,
or scoping,
just simply scoping it. Yeah, just an arthroscopy where you go in and clean out the joint, with the camera, just like you would with a knee or a hip. So yeah, that's absolutely an option for a lot of these folks, as long as they have a joint. If there's no joint left and it's completely arthritic, then we'll usually talk to most folks about either replacement or fusion.
Yeah, nerve injuries. This is kind of your specialty.
Yeah, my practice, again, that video, where do you find these? That guy, oh my God, that's crazy. Peripheral nerve injuries, neuropathy, entrapment neuropathies have become about 75 or 80% of my practice over the course of the last 15 years. And so we spend a lot of time treating patients that have been referred to us from other surgeons, either with failed previous nerve surgery where the nerve's been decompressed or nerve has been removed and now the patient still has pain. We're a very nerve preservation practice. We try to preserve nerves. We're not looking at removing Morton's neuromas like you see in that center picture there.
We decompress.
Yeah, decompression or very similar to what hand surgeons do with the carpal tunnel. It's you don't take that nerve out. You decompress it. You free it up. You give it more room. And we can do that with the majority of nerves in the lower extremity that become entrapped. And one of the biggest problems that we see that gets misdiagnosed are traction injuries. A traction injury is where the nerve gets stretched, and nerves really don't like getting stretched, and that can happen very easily with an ankle sprain. So when you roll that ankle, and you can see on that far right, the superficial perineal, it's now called the superficial fibular nerve. Actually, the anatomists have changed that name over the years. But that nerve is at risk, and if it gets stretched, I saw a patient this morning that was referred to me for this exact problem. He had an ankle sprain in 2016. The ankle sprain healed up fine, but progressively over the last 4 years, he's had more and more neuritic pain, which is burning, stabbing, buzzing sensation all along the course of that nerve. We blocked his superficial perineal nerve in the office, and all of his pain was gone. Pain that he'd been dealing with for 4 years now, or 3.5 years. And that tells me that we can have an impact on that nerve. We're going to have to decompress it surgically, most likely, and put him on some supplements to try to upregulate, I think, his nerve function. But I think he's going to do really well. When we tap over that nerve along the course of that nerve, he gets zingers out into his toes. Straight out of the textbook, this is a classic example. He has none of those symptoms on the opposite side, and he doesn't have the same history of ankle sprain on the other side. So, you put 1 and 1 together, it usually makes 2.
But you got to know what you're looking for.
Yeah, I think that's the real key is that most people, their index of suspicion for a nerve injury after someone has an ankle sprain is pretty low.
Yeah.
They're not thinking nerve injury. They're thinking cartilage. They're thinking ligament. They're thinking tendon. And that's, I think, legit for the first 3 to 4 months. But when that stuff all heals and the patient's still struggling with neuritic pain, that's very different than bone pain. Nerve pain is burning, tingling, stabbing,
numbness,
shooting,
paresthesias.
Paresthesias is a description of buzzing, tingling kind of pain. That's not related to the soft tissue injury. It's related to a nerve injury.
Yeah.
And so that's where I think we get these folks who've been kicked around by the system. They've seen 5 or 6 or 8 docs, and everybody's pointing in different directions, and the patient's getting frustrated.
I feel like a lot of them end up going to pain management. And
Unfortunately, this guy has already had a spinal cord stimulator placed.
Wow.
And all he needs is a decompression of his superficial, his deep, and his common perineal nerve.
Yeah.
I mean, this is a 45 or 50-minute surgery, outpatient, that he'll be feeling great, hopefully, in about 2 to 3 months.
Yeah.
But the spinal cord stimulator was an attempt to blunt the pain from a problem that was correctable.
Yeah.
That's the frustrating part. It's a very expensive modality that has potential complications that what really wasn't necessary if he had been referred to the right place. And so we're getting the word out. Part of that is this podcast, is to let people know that peripheral nerve injuries in the lower extremity oftentimes can be addressed surgically, and they do quite well.
Yeah.
So I'll get off my soapbox.
Gout. So
we finally have some new stuff for gout. I mean,
Yeah.
for decades, we've had allopurinol, probenecid,
Uloric.
but no, not, this is. But you're in the Uloric because you're a
so
newbie.
Uloric is
I'm talking like
relatively
40,
new.
30 years.
Yeah.
We didn't have anything new, and then Uloric did come down, and there's a couple other drugs that are being studied right now that are coming out. But indomethacin was the acute pain medication that we all used,
Yeah.
and colchicine's another one. You're supposed to dose it until the patient throws
diarrhea.
up, and diarrhea, and that sounds like fun, right? So, but gout's an interesting one because they call it the great masquerader, and that's because it can look like an infection. It can look like maybe the patient had a fracture. It could look like even Charcot in some cases. So, but this is usually in non-diabetic patients. I wouldn't say non-diabetic, sorry, in patients who don't have neuropathy. These are clearly people who are sensate. And it is a problem with the uric acid system, where uric acid is building up as a byproduct of the foods we eat.
That's a rich man's disease.
They used to call it that, because only the wealthy could afford the red meat and the chocolate and the alcohol. Shellfish, exactly. So, but now we do see people who are just under excretors and they just can't get rid of it.
Yeah. Certain medications that
certainly
cause it.
Yes, you can see it in people who are on
beta blockers.
Beta block. Well, not also just people who get dehydrated because they're on water pills or on furosemide or one of the Lasix, one of these other drugs that can deplete your fluid, and then these crystals come out of solution.
Yeah.
So it's almost like if you have a glass of warm water and you're trying to put some salt in there and get it to go into solution, and you'll see the salt disappear, but you eventually put enough salt into that, it's maximized its ability to go into solution, and now you're seeing it crystallize at the bottom of the glass. Well, that's what's happening with these gout crystals. They're getting into the cooler parts of the foot, and those joints being the furthest away from the heart are the coolest joints, and the great toe joint being the most classically involved, and those crystals will come out of solution, and they cause tremendous inflammation.
It's literally ground glass in your joints.
Oh, it must hurt it must hurt incredibly. I mean, like kidney stones and childbirth. Because patients will come in and be like, "Doc, I don't know what I need to do with this, but if you can't fix this, we need to cut this off because I'm in that much pain." Thankfully, the drugs that we have access to seem to be able to cool it down pretty quickly, and we have new things like Uloric and some of these other.
Have you tried Krystexa yet?
No, I have not.
So Krystexa, we'll go through gout, but Krystexa is this new IV medication that will literally break down the uric acid and flush it out of your body. And their claim to fame is that you're not going to have a flare-up for years and years on end.
And how often do you need to do the infusion?
So the infusion is like your IV antibiotics. It's a course. It's like
Okay.
You come in every few weeks, or they can even do it at my home now. And they literally. I have patients off of medications thanks to Persexa.
Oh, that's terrific. That's terrific.
Yeah. So we'll go through this.
I've not heard. I need to see the rep. I haven't seen that one.
So.
But yeah, that is one nice thing about gout these days is that we have some new options for the first time in decades.
Yeah,
it's
I had this
amazing.
I had this old school doc back when I was in like third, fourth year med school, and gout is one of those things that oddly enough ice makes it worse because just like with sugar and water, the more you heat up the water,
you're cooling off the joint, you're crystallizing it out worse.
Yeah,
exactly.
So he would say if a patient tells you that ice is not helping him besides making it really cold and numb, then you want to look towards gout. Yeah. And he said sometimes you would even just take a bag of ice and put it on their foot, and the patient was just like in excruciating pain. You knew that it was more likely gout than it was anything else. And that's when you go through your other checks.
Sure. We usually get blood work on
labs,
these folks.
Yeah.
We're looking for a complete white count to make sure their white blood cell count's not elevated, it's not an infection. Yeah. We get an uric acid level.
Uric acid,
but you can see, even in that lower left patient picture, you can have a red hot swollen joint, and maybe it's heading down, it's getting better, and their uric acid will fall into the normal range. Yeah. But even if they're high end of normal, and I see a joint like that, I'm like, you got gout.
Yeah, the logic behind that is that it's already sedimented. The uric acid it's
out of solution.
Yeah, it's under normal limit, but it's still higher than normal.
Yeah.
It's under pathological limits, but it's still under the diagnostic limits.
Yeah, you're within the normal range, but high end of normal with a joint like that, ding, 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 you got gout till proven otherwise. Yeah. I don't think it's necessary to aspirate these joints or to pull fluid out necessarily, because I think that's kind of mean. Yeah. That would really hurt. Yeah. So I think usually it's a pretty good clinical diagnosis. The interesting thing you'll find, though, is I think in premenopausal women, it's actually pretty rare. In postmenopausal women, it averages out. It starts. They can get it almost equal to men, but typically, younger folks, you're going to see this in men far more than women.
Very common in bodybuilders because of the high purines that they take in.
All the protein shakes and supplements and stuff can lead to that. Absolutely.
Next, soft tissue masses, and this is from like lipomas to ganglions to anything in between.
Even other benign tumors. We do see tumors in the lower extremity. Thankfully, malignant tumors in the lower extremity, primary malignancies, are really rare. Yeah. So other than melanoma, other than dermatologic cancers. But yeah, ganglions are very common. They used to call them Bible lesions because you could theoretically whack them with a book and pop them, but they heal up. The sac will heal up and it'll fill up with fluid again, and you'll end up with the same problem in a few weeks.
Short-lived.
Yeah, short-lived. I think aspirating these sometimes helps, but again, you're popping a little hole that's going to fill up again. So until you go after the stalk, and that picture on the bottom left that you have there is a great picture of that, because you can see that's actually a synovial cyst. It's coming from a joint. So if you really have to go after the stalk, you either have to tie that off or cauterize that in the operating room, and you'll keep these from coming back. I took one out of an ankle about 3 weeks ago that was massive, and it completely enveloped the entire front of this lady's ankle. Mm-hmm. Biggest one I'd ever seen in the lower extremity.
And they're not solitary every time.
Sometimes
they'll be
loculated. Yeah, you get little pockets here and there, and that's exactly what this one did. It wrapped around 2 or 3 of her tendons in the front of the ankle. It was crazy. We sent it off because we were kind of worried about a pigmented villonodular tumor, which can become malignant. Thankfully, that's not the case. It was just a ganglionic cyst, but a synovial cyst.
Yeah, so pretty much what happens when you have a ganglion is your synovial tissue. The synovial tissue is the lining of your joints, your tendons, your tendon sheets, and it'll become weak or it'll have...
It can be injured. Sometimes blunt force trauma. You get stepped on by somebody, you get whacked with a shopping cart. That can lead to it.
Yeah, and it'll pretty much outpouch like a hot truck tire, that kind of gets that weird bubble. Mm-hmm. Same thing. It finds a weak spot, outpouches, the synovial fluid gets bigger and smaller throughout the day. A common thing that people will say is, in the evening it's bigger. In the morning it's not too bad, but in the evening it's far bigger. It's pressing against my shoe or my boot or whatever. And we'll just literally go in, excise it, cauterize that stalk or tie it off, and that'll be the end of it. Very simple.
Yeah, there's a 20% recurrence rate, I think, in the literature, but in my practice, because I think we spend so much time going after the stalk,
Yeah.
My recurrence rate is extremely low. It's probably less than 5%.
Yeah, that's key. I mean, taking the source out.
Absolutely.
Wound care.
Oh, I mean, this is part and parcel with what we do. Diabetes in Texas is really out of hand. They expected, this was stats from 3 or 4 years ago, but they expected by 2020 we'd have 4 million diabetics in Texas. I think we're probably pretty close.
Yeah, if not past that.
I kind of joke that, we can turn a non-diabetic into a diabetic here in Texas in like 2 years. We just, feed them a bunch of great Mexican food and feed them a bunch of beer, and we're going to get a diabetic pretty quickly with our diet here, unfortunately. But it's clearly being driven by the obesity problem, which is a nationwide problem. But specifically, these folks end up with sensory loss, and it's not every diabetic that ends up with neuropathy or sensory loss, but those that do end up with these wounds, like you can see on the left there, a malperforans or a neurotrophic ulcer that is limb-threatening and is as dangerous as colon cancer.
Yeah.
And I think that fact is surprising to a lot of folks. And I say that to my patients who come in with these, and I say, look, I need you to understand that this wound is as dangerous as colon cancer, and they kind of look at me like I'm crazy. But if you follow out the morbidity and mortality of these lesions over time, they are as dangerous. And if you have vascular disease or blood flow problems in addition to these, it's even worse than colon cancer.
I want to say it's like 5 or 6 times more likely that you're going to get an amputation.
Yeah, and 85% of these wounds that lead to amputation, those amputations were preventable.
Yeah.
And that's an optimistic thing that we should focus on. But it's also frustrating when the patients wait too long to come in, and now we've got bone infection, and we're dealing with osteomyelitis, and we've got to do partial foot amputations.
They have no sensation. They have no sensory, or they have no pain with it. They're like, oh, it wasn't bothering me. It's just a little sore. It's a little a wound. It's a blister or whatever you want to call it, and they don't see the extent of it. And we'll go through, we'll clean it up, and we'll see. Look, it's broken to tendon, it's broken to muscle, it's broken to bone, and
Paul Brand said that sensation, the fact that we had pain, he called it the gift of pain.
Yeah.
And it really is, because when you don't have the motive, if you don't have that motivating factor, that pain, you're going to let things go. It's just kind of the path of least resistance. And once we get patients into the system and we're treating them routinely for diabetic foot problems, we really let them know, hey, look, we're here 365, 7 days a week. Someone's on call with our practice. If you have a problem, don't wait till Monday.
Yeah.
If you think you're heading down the wrong path Friday night, get to the ER, have them call us. We can take care of this. It's much harder to go back. Like your picture A, B, and C here of this patient, who this is probably like a combination wound, maybe a burn wound with a pressure wound.
Yeah, it looks more ischemic in the first couple pictures.
It does, but then they granulate in beautifully.
So
I'm not sure what the etiology was there, but clearly that patient was in a limb-threatened situation in A and B, and by C, it's stable, and that's a tremendous result. I mean, that patient's very lucky that they didn't lose a limb over that. And, you see patients who have the wounds in the bottom right. Those are classic diabetic foot ulcers. You can't get these to heal if you keep walking on them.
Yeah.
And I tell patients that from the very beginning. I'm like, look, every step you take on this wound is killing more tissue and making it impossible for your body to heal this. Yeah. We get vascular testing on these folks. We work very, very closely with our interventional radiologists and our interventional cardiologists and vascular surgeons on trying to get perfusion, making sure the patient has blood flow, because without that, there's really nothing we can do.
Yeah, it's a team effort. I mean,
absolutely.
Vascular, podiatry, infectious disease, and endocrinology in your primary care medicine. I mean, we're working all in this one group to help try to
prevent these amputations. So I like your picture on the top left. If this pic bothers you, then you are lactose intolerant. You don't want to end up with that patient. You don't want to be that patient, because even that partial hallux amputation throws off the mechanics. That patient's 50% more likely to end up with another amputation within 2 years.
Yeah.
and that's preventable. So we get people into diabetic shoes. We protect their feet once we get them in the system here.
You can do those smart socks.
Yeah, I think the Siren smart socks are really amazing. We may have to do an episode on that and bring in the Siren folks and have them talk a little bit more about that, because this is a new technology using smartphone technology and electronics that are built into these socks that can measure pressure and temperature.
Yeah.
And we know from studies over the last 2 decades, some by Larry Lavery and David Armstrong, showing that you can measure temperature and pressure in these patients and know where they're going to get an ulcer and almost when they're going to get an ulcer.
Yeah.
And so these socks can send signals to a central monitoring station that's reading all this data, and then they can call us and say, hey, look, Mrs. Jones is heading down the wrong path. She's got an area under her great toe that is about to ulcerate if you don't get her in right away.
Yeah.
And then we can call the patient, get them in right away, and they haven't broken down yet. And that's the best time to see them and be able to say, okay, your shoes, we need to change your inserts because you're getting a pressure point here. And we can show them where the pressure is and how we're going to offload it. That's way more effective than getting to this point, in this patient in your amputation picture.
Yeah, you're working upstream when you're doing it at this point.
Yeah. So I think using pressure and temperature and using these smart socks to be able to diagnose these folks with problems before they end up with a wound is really game-changing. And I think it's going to be exciting. We're trying to get more and more of our patients to jump on board. It's covered by insurance. Certainly the Medicare plans are covering it. So that could end up being a huge game changer.
Yeah, it's prevention because, next picture, we're talking about amputations.
Right.
It's probably the worst conversation to have with the patient.
It's the least fun thing we get to do.
Yeah.
By far.
So we're telling them, look, your foot's at that point where it can't go backwards. We're not able to reverse it.
And you can see this picture here. This is clearly a patient who has a vascular problem. Yeah. So this isn't from an infection. This is blockages in the arterial flow down to the foot. Diabetic patients are more commonly suffering from this based on a number of different issues, but they clearly lay down plaque easier, and some of them are also smokers, and that combination is just brutal.
Yeah.
That combination is causing all kinds of problems with blood flow in the lower extremity. The main area of entrapment seems to be of narrowing is behind the knee because of that trifurcation disease. You got one vessel splitting into 3, you get lots of turbulence, and the thought is that that's allowing plaque to be laid down in a much more aggressive fashion.
Yeah, a lot of patients think this. That just happened from last week. I was at the barbecue and I had my foot, too close to the fire. I wore tight shoes that day. I wore new shoes. This is years and years of buildup.
There may be something that pushed it over the hump, but clearly this isn't going to happen over a weekend from some incident in someone who has completely normal blood flow. And the other thing is, this would be excruciating long before you get black toes in someone who has normal sensation.
It's that sensation where you tie your finger off with like a rubber band, and you get that deep ache when you're young.
Ischemic pain is brutal. Yeah. Narcotics don't work well for it. So the fact that these patients are also neuropathic oftentimes means that the changes can occur rapidly, and they're not going to know it.
It's a vicious cycle.
Yeah, and so that's really the scary part.
Yeah.
So we work very closely with our vascular interventionalists, and we're trying to identify these folks and who would benefit from vascular intervention to have these blood vessels opened up before they end up in a situation where they have gangrenous toes.
Yeah, and like we said before, as far as podiatrists go, we see a lot of diabetic foot problems. Amputations, their statistics are that one major limb amputation, within 5 years, you're more likely to have the opposite limb amputated.
And if it's a major amputation, the mortality rate is 65% at 5 years, depending on who you read.
Yeah, it's significantly high, and that's what we're trying to do. We're trying to prevent all these problems from occurring and work backwards and get back to a healthier state.
And sometimes an amputation is still a success. If you're doing a partial foot amputation rather than a below knee amputation, that's a huge benefit to the patient. And we know this from studies that are looking at cardiac output. These people already have cardiac output issues. And if you ask them to walk with a prosthetic limb, I don't know about you, but I've been doing this 21 years. I can count on one hand how many of my below knee amputation patients have actually gone through the rehab and walk with a prosthetic limb.
Yeah.
It's less than 5.
Yeah, it's not often.
It's not often because they don't have the capacity. They don't have the energy stores and the perfusion and the cardiac output to do the work to be able to walk with a prosthetic limb. And they usually end up in a wheelchair, and many of them are not around within 5 years. It's really sad.
End up in a wheelchair, in a rehab facility or a long-term acute care facility because they can't take care of themselves. And it's not just, you're a young, healthy individual and you can hop around on one leg.
Yeah, traumatic amputations, 20-year-old who has it blown off, God forbid, in Afghanistan or Iraq, those guys do great because, they're not smokers, they don't have diabetes. But in the diabetic patient, it can be a death sentence. And so that's really why we go to the ends of the earth to try to save limbs or as much of the limb as possible, because the chances the patient's going to stay functional are so much greater.
Yeah. I mean, that's the end of the lecture, end of conversation. We're podiatrists, we're here to help. Your feet are important, and, go see your local podiatrist. Get checked out.
And you've got some great stats here about diabetes. I mean, I mentioned the Texas Diabetes Council stats from a few years ago where they thought we'd have 4 million in Texas by 2020, and by 2040 we'd have 8 million. 8 million diabetics in Texas in 2040, if that really does come to fruition, that'll be 1/4 of the state.
Yeah.
The amputation rate that would go along with that, just on the normal course of things, will be overwhelming. Yeah. And there aren't enough of us dealing with this. In 2020 and 2040, we're going to be so far behind that a lot of this care is going to get sloughed off onto secondary providers or ancillary providers, nurse practitioners, people who don't necessarily have all the skill set to address the full gamut of problems in the lower extremity or have the biomechanical and anatomic training that we do. Mm-hmm. And it's going to be worse. So we have to get ahead of this as quickly as we can now. And maybe things like the Smart Sock, maybe things like Siren socks will help us identify these people before they end up with the ulcers, and we can prevent the amputations that way. We need some help, though, because there aren't enough of us to address, just in the state of Texas, all the patients that we're going to have to treat in the next 20 years.
Yeah, that's what we're really working towards, prevention. And we're not trying to, get to the point where we're talking about amputation. We're trying to do things before it even becomes a sore, before they get neuropathy, before their diabetic, A1C is sky high. We're trying to do everything we can so we don't get to that point, so we're not seeing all those amputations. And
so every hour, 10 Americans undergo an amputation due to diabetes.
Oh yeah,
that is a scary stat. And 25% of people with diabetes, will develop foot ulcers, and the recurrence within 5 years is 28 to 51%. I have something to say about that. So my close friend and orthopedic surgeon who's retired now, Scott Nickerson, he actually published a paper with some of my other colleagues looking at the recurrence rate after a nerve decompression. So after decompressing the tibial nerve, the common fibular, deep fibular, superficial fibular, and the lower extremity for this particular problem, for people who had neuropathy, painful neuropathy, but were also having ulcers, that you can reduce that recurrence rate down to 3 to 5%.
Wow.
After that surgery. And we know this because there were patients who had only had it done on one side and ended up continuing to ulcerate on the side that they hadn't had done yet. So that is a fantastic study. There's another study by Shai Rosen, who is a plastic surgeon down at UT Southwestern here in Dallas, who has an ongoing study. It's a randomized controlled study using every specialty you can think of that has to do with diabetes, looking at the applicability of nerve decompression in these folks and whether or not it actually works and whether or not it's effective. It's an ongoing study, but they're already finding that these patients benefit from this surgery when they're selected appropriately. And what I mean by that is these are people who have a mix of painful and sensory loss, neuropathy. They have reasonably controlled diabetes, and they're at risk. And those folks do extremely well. And we're hoping to see multiple subsequent iterations of this paper because it's still ongoing. Dr. Rosen and his colleagues at UT Southwestern are still tabulating all this data that they've collected over the last several years. But I think the preliminary data is very favorable for this technique, which I think has been I think it's been poo-pooed and even lambasted by certain specialties, including neurology, who didn't think that you could actually have an impact on the diabetic neuropathic patient. They felt that it was a stocking glove progressive problem that wasn't a surgical problem, and
that's why we need the literature. That's why we need research.
Absolutely. And I think that the disconnect there was that people were assuming we were treating the diabetic neuropathy. What we're treating is an entrapment neuropathy on top of what's happening metabolically to the diabetic nerve, and I think that's what's very different. Patients who have diabetes get carpal tunnel 30% more likely than non-diabetics.
Yeah,
There's a reason for that.
Yeah, their soft tissue, it's been shown that they have excessively more cross-linking of the collagen
It
fibers.
gets stiffening of ligaments, stiffening of the tunnels themselves, and you get a nerve that becomes swollen, osmotically swollen.
Yeah.
There's the theory, the sorbitol pathway theory, where the nerve is taking in the sorbitol, which is a byproduct, sort of a cascade byproduct.
The nerve sheath.
The nerve sheath.
Yeah,
but you're also seeing you're seeing edema in the entire nerve.
Yeah.
And that edema, that osmotically mediated edema, these nerves are 2 to 3 times the normal size of non-diabetic nerves sometimes. I published a study in 2005 that was published in the Journal of the American Podiatric Medical Association, looking at ultrasound studies of non-diabetics, diabetics with neuropathy, and diabetics without neuropathy.
Mm-hmm.
And what we found was, and this is a relatively small study, but it was effective because it was showing that with ultrasound, you could measure the cross-sectional area of the tibial nerve in a non-diabetic and a diabetic who had no neuropathic symptoms, and they looked about the same. They were about 12 millimeters squared. But when you looked at the diabetic patients who had neuropathic pain, who had sensory loss, their nerves were 2 to 3 times the normal size, trying to go through the same tunnel. So you've got, this tiny little tunnel, and the nerve is trying to go through it, and it's 2.5 times the size. It's getting squeezed and pinched, and that causes burning, tingling, numbness. And if it's not addressed, you end up with, basically nerve death, where the nerve is no longer functioning. And when you see these patients, when you do tarsal tunnel releases on these patients, the intrinsic musculature in the foot should be red and beefy. It's pale. Yeah. You can see through it. It's translucent because there's no more function. You have a denervated muscle now. And that's why they end up with the hammer toes and these horrible deformities when they suffer from neuropathy. So anyway, I'm totally going on a massive tangent on diabetic foot, but it's necessary because it's one of the major problems that we see, and it's not going anywhere, unfortunately. Diabetes is the 7th leading cause of death in the United States, and that doesn't look like it's going to change anytime soon. Hopefully, in our lifetime, we will find a better way.
Yeah.
Right now, we gotta cure COVID, but the next thing we need to figure out is what can we do to eliminate diabetes from the planet, because it's one of the few problems that affects so many different organ systems. It affects your eyes, your nerves, your kidneys, your heart, your entire cardiovascular system, your skin, your ligaments. I mean, all the glycosylation of all these tissues is causing damage. Yeah. That's like the only thing I can think of it doesn't affect necessarily that I'm aware of is maybe your lungs and your liver, maybe. I mean, I can't think of any direct impact on the liver. So, can you imagine other medical problems that we're treating that have that kind of impact on major organ systems? It's really scary. I wouldn't wish it on anybody. But it's a very manageable disease process now. Yeah. It's really scary. I wouldn't wish it on anybody. But it's a very manageable disease process now. Yeah. I mean, we can do a better job. There are all kinds of ways that we can measure blood sugar and do that more effectively and help people be more compliant, where they can keep their blood sugars under control and avoid a lot of these complications. People can live a nice long life with diabetes now.
Yeah. Back in the day when you had type 1 diabetes or juvenile diabetes, it was a death sentence.
Oh, absolutely.
They were expecting people to pass away around 30s, 40s.
Yeah, they just couldn't tolerate it.
Yeah, and now we have such well control that you'd never even know that they were diabetic.
I have a type 1 diabetic in my practice now who's had it for 50 years. Yeah. So, she's doing great. But that, I think, probably kind of ends our conversation today. We're heading up on an hour. We did a good job.
Yeah, that was a fun topic.
I like your last little gif here of good old Jim Carrey with his Hobbit feet. That's classic. So both feet make up 25% of the body's bones, 18% of the joints, and 6% of the muscles. and 100% of the problems that walk in our door. Thankfully. But we are the Pod Doctors, and we hope to give you guys some educational information and do that for free. We would hope that you would subscribe and like us and go to our website, thepoddoctors.com. Look into our medical mission project, which is the Los Niños de la Frontera project through the Texas Podiatric Medical Foundation, which is a charitable organization that has outreach to folks all over the world. We have programs that are dedicated to trying to help folks specifically in San Miguel de Allende, Mexico right now. We had some relationships with hospitals down in Reynosa, Mexico, and we've transitioned that to San Miguel, to the Hospital General in San Miguel. And we are recognized by the Mexican government and have been providing care for those folks for several years now. More information is on our website, and you have the opportunity to use our GoFundMe for our medical mission project. If you have the time, please go take a look at that, and we would greatly appreciate it. But until next time, we are the Pod Doctors. I'm Dr. Damien Dauphinee.
I'm Dr. Hussain.
And we will see you next time. Thank you.